Hey everyone, just confirming the audio's okay. If anyone can hear me, please just type in the chat when you can. Just signal to me that we're not having any technical issues. So I know this is probably a bit of an unfamiliar platform. Oh, awesome. Yeah, thanks, Adipta. Harrison, beautiful. Good to see you, Adipta. All right, we'll just let a few more people flood in, and then we'll get stuck in. Uh, there won't be too many people joining us this evening, I think. Yeah, good to see you, mate. There won't be too many people joining us, so we'll keep this nice, quick, punchy, useful. I know you've got your OSCEs coming up quite soon. I fucking hate 1 hour long lectures, so I make a point of not doing that. So we'll be nice and quick. While we sort of wait for a few more people to join, I hope you guys sort of enjoyed your 7 days with Oscar. In case you weren't aware, you had a bit of a 7 day free trial up until now. I hope that's been useful, and hopefully over the course of these sort of 25, 30 minutes, I'll sort of show you how I recommend you use it to ace your histories. Sudipta, do you know how many we're expecting? I know somewhere in the order of sort of 20 people have registered for this. Yeah, cool. All right. Well, we'll get stuck in there. Welcome, guys. We're Oscar in the Oscar office right now. I know it takes there's a lot of friction in sort of dragging yourself to an extracurricular event. So we'll keep this nice, quick, and punchy. For those of you who don't know who we are, we're the virtual patient platform, the most intelligent medical student software that exists. We use AI to simulate what a patient encounter would be like. History only so far. We are working on developing an exam mode at the moment, and hopefully you found your 7 day trial useful. And if you haven't used it yet, there are a couple of free cases you can always use, so feel free to hop on that. So our job today is very quickly in advance of your impending OSCEs, some quick things you want to remember to make sure to ensure that you do really well. Now, I'm not interested in sort of teaching you how to pass this thing. Passing an OSCE is ridiculously easy. Okay, and we're gonna in the first two slides. If you can sort of remember the first two slides, you will pass this thing. It is about how to destroy an OSCE. Okay, and it's actually really easy to do that because you're really sort of early on in the process. So, Dip, to just remind me, I'm speaking mostly to MD1s here. Is that correct? I'm going to assume I am. Okay, so we'll keep going. So I want to introduce you to a concept very quickly. Now, there are a lot of ways to describe this. Some people call this the pre-test probability. For this OSCE, you're going to be testing on MSK, RESP, cardio, and renal. Only MD1. Yeah, beautiful. So that's actually perfect. There's this concept that you want to get across very quickly, which is the base rate of disease. Some people might call this the pretest probability, and it is the idea that sort of approaching a presentation, whatever that presentation is. You only have a few sort of subjects here, but it could be anything. It could be headache, could be chest pain, whatever the case may be. Immediately, from an epidemiological perspective, there are things that will be more likely than other things, and at the MD1 level, the cool thing about the level that you're at is that the cases you're given tend to be fairly pathognomonic. What I mean by that is they tend to be pretty sort of characteristic. If you see 41-year-old Melissa presents with abdominal pain, they're probably leaning to something a little bit, cholecystitis-y. There's something in that sort of area. They're not trying to trip you up. So the base rate fallacy is a fallacy where people ignore the base rate in favor of individuating information. The OSCE is a process of discovery. As you go along the OSCE process, as you ask more questions, more and more information is given to you, and that might skew you to more extreme conclusions. But hopefully, what we're going to be sort of showing you very quickly in the headache case that we do at the end of this thing is that you want to sort of stay true to the base rate of disease before speaking to the patient at all. Organize the differentials by pretest probability. What's more likely, what's less likely without asking a single question? We're going to call that the base rate of disease. Another thing I want to discuss quickly is a bit of context. This is your degree, the Sydney Medical School degree. It's a 4-year degree. This year, and I'm not at all going to say it's easy. You're learning a language, a kind of language and grammar of speaking to a patient. It's going to get easier with time, but there is something that you do benefit from here, and that's important in the context of how you're going to score on this OSCE. And it is that this year is not about you finding a diagnosis. This year is not about you managing or investigating a patient. This year is about you learning that basic structure, that basic process of an examination or of a history. Basically, it's, can I throw this medical student at a chest pain patient and they can kind of sort of like equip themselves okay. And that's a good thing, because what it means is the diagnosis is actually not that important for your OSCE score. Okay, you can score a really good score and not actually know what the diagnosis is because you followed the process. That's important to remember. Okay, I think it accounts for, different universities do different rubrics, but it generally accounts for a very tiny percentage of sort of bonus marks. But your fate is basically set by the time you get to sort of the diagnosis side of things. And over those 4 years of your degree, the thing that the university is trying to teach you is how to not murder patients, sort of red flag conditions, red flag symptoms, that sort of thing. It's not about zebras. It's not about a cerebral venous sinus thrombosis. It's about, acute coronary syndrome, the shit that will kill a patient in front of you. So you've entered the room, let's say it's a 7-minute OSCE. There is actually a lot you can do before you even ask a question. All right. And what I want you to say, this is, pretend this is an Oscar case. Madeline Smith is a 30-year-old patient presenting to the emergency department with complaints of chest pain. This is the thing you would see on the proverbial wall. I think, they probably still Zoom OSCEs if it's anything like the University of Melbourne, which is where I've studied. It is, a room before your OSCE room. You're given this prompt. Madeline Smith is a 30-year-old female presenting to the ED with chest pain. So Sudipta said you have rest cardiorenal MSK. So this is within the scope of what you might be able to see. There are 2 things you're able to do. The first thing is quickly develop a snap differential based on the base rate of disease. That's not a comprehensive differential diagnosis. If you go to Tally, O'Connor's, Amboss, whatever the case may be, and you go to chest pain, you're going to see everything from acute coronary syndrome to Dressler syndrome, right? Like, what's Dressler syndrome? That's a post, 2 weeks after an ACS, you can get like a viral pericarditis. It's a super rare thing. That shouldn't be in your head when you're seeing this case. You organize sort of like the 6 most likely differentials according to the base rate of disease. The second thing you can do in that 1-minute reading time is you categorize Madeline's presentation into one of 2 categories. Is it the kind of presentation that has a regular set of questions that are specific to that presentation, okay? Or is it a presentation that requires a head-to-toe assessment? That's a quick categorization you can do. An example of the former would be most presentations, really. Abdominal pain, chest pain, headache, some urinary symptom, dysuria, hematochezia. All of these things are a specific kind of presentation that requires a specific kind of approach. To a certain degree, obviously, all pain cases sort of have the same questions associated with them. And there are presentations that require more of a head-to-toe assessment of the patient. One of them is fatigue. Another one might be falls. Another one might be lightheadedness, palpitations. That's a category of presentations that doesn't have a specific structure associated with it, but needs you to screen head to toe so that you can find that diagnosis. So you've seen the patient, you have 1 minute. Base rate of disease, what category of presenting complaint. Now, before I go any further, right, this is kind of the hard part. So I'm not sure exactly what day. I know I think it's on the 28th, right? I think I've been told your exam's on the 28th. So you have a ton of time because I don't spend more than a day prepping for these things anyway. So you've got plenty of time. So what do you want to be doing with something like this? I personally use Notion, as most people sort of tend to do. And you can do something very simple. This is something you kind of need to do pre-Oscar, which is uh, just sort of create a database. It can be Google Sheets, it can be a pen and paper, whatever the case may be. Okay, so this is outside the confines of Oscar. Oops, let's get my keyboard working again. Yeah, awesome. So let's create a database. Uh, you know, and we sort of list the presentations that we've been told are going to be part of our OSCE. Now, sometimes they're prescriptive about this, sometimes they're not. It seems like you guys have a fairly decent idea of what you're going to be assessed on. Some MSK conditions, whatever it is, knee pain, shoulder pain, they tend to be sort of painy type things anyway. Rest, cardiorenal will be pretty easy to sort of figure out. And you just list those presentations, all right? So maybe we have, chest pain, all right? We get like a little heart in there. Have I, let's say that's a checkbox. We can say this one's studied or prepared or done, some variation of that. And we can be infinitely more complex with this database. We can sort of roll it up into different conditions, whatever the case may be, create relational databases. Not important right now, but you want to have a basic catalog wherever it is, pen and paper, Google Sheets, Notion, of different presentations. And what you don't want to do in them is, sort of write down sort of every differential that might be in chest pain, ischemic heart disease, dissection, go all the way down to Dressler syndrome, PUD, pancreatitis, whatever the case may be, and write a laundry list of things about each one of these conditions, right? That's not what you want to be doing. What you want to be doing is just a quick, simple, like base rate of disease, the 5-6 likeliest things for this condition that you need to know, maybe which ones are red flags, which ones are not, and a basic history approach if it is any different from like a regular pain approach. So you would know how to do a pain history by this point. Ask how bad the pain is, ask where the pain is, when it came on, is it always there, is it constant, is it episodic, does it, has anything relieve it, does anything aggravate it, whatever the case may be. If there's anything specific to chest pain that doesn't apply to a regular pain history, you want to have that there. The idea is you want to keep this as light as possible. As light as possible. You don't be writing any information about the databases, and you can track it very simply. So an example of the sort of thing I would have been doing is this. This is what I've been doing over the past sort of couple of years. Just simple schemas for some of these presentations: bleeding, bruising, dizziness, wheeze, back pain, breast pain, nausea, so on and so forth. So this is some of them. But what you can do is it's going to be MSK, rest, cardio, renal. So there are only sort of like 4 cardio conditions that you're probably going to get. And you can use Oscar for that as well. All right. So you can actually use Oscar to see what sort of conditions you might get. Shortness of breath, chest pain, palpitations, leg pain. Is there anything else here? No, you're probably not going to get a cardio presentation outside of those. And you can produce a quick base rate of disease for those 4 presentations. So you can see that this is very simple already. This is about 1 day's work at best. This is a simple base rate of disease and any distinguishing features of that history for each one of those four areas that Sudipta has given me. That's the work you need to do beforehand. You can use whatever resource you like. You can use the Learn Mode and Oscar to do it. You can use Amboss. I like to use Amboss. Some people like to use UpToDate. It doesn't matter, but the idea is keep it as simple as possible. So you can see, as an example, I think my headache one is fairly simple. Red flag conditions, differential diagnosis. Look at that. So that's not the actual full differential diagnosis. This is my base rate of disease list, okay? The full differential of headache includes things like giant cell arteritis and that condition, that cerebral venous sinus thrombosis condition I mentioned earlier, and a host of other things that can cause headache. But what I want to do is when I see that prompt for the first time, I have that base rate of disease. So that's the hardest part. Now we can fly through this. Okay, let's go back to the presentation. I'm going to come back to the screen in a second. So you've already done this. You've done most of the work so far. You've done most of the work so far. Now, the the well, actually, one more thing I want to mention before we sort of race through the rest of this and get into the case is that your history is going to be composed of three parts. Your history is going to be composed of three parts. The diagnosis is only a very small part of that part. One is presentation specific stuff, characterizing the presentation. Now we know how to do that because we've created our database of, maybe 15 presentations that you might be possibly examined on: dysuria, shoulder pain, leg pain, chest pain, whatever the case may be. Next, it's a set of stuff that you shouldn't miss because in the rubric, there is a mark associated with those things. All right. So it's bread and butter stuff that you might think is actually the commonly missed areas: past medical history, meds, family history, social history, drugs, alcohol, smoking. Are you vaccinated? Do you have any allergies? What do you do occupationally? Who lives at home with you? These basic questions, even if you don't think they're important to the case, there is a mark associated with each one of these things. So in the pursuit of getting 100% on this OSCE that you have on the 28th of June, it's easy to get caught up in the presentation specific stuff and then lose dumb marks because you didn't ask about allergies. All right, that's important. And in the inverse, it's also a buffer. If you sort of mess up some of the presentation specific stuff, it's also a buffer because you're collecting marks anyway. And that's what I mean when I say it's like super easy to pass this thing. Now here's the thing that probably will save you the most time. The biggest difference in the way an MD1 takes a history and the way an MD2 takes a history, I feel, sort of just from experience, is the way an MD1 tends to dither about in trying to balance the tension between speed and efficiency, and politeness, courtesy, good bedside manner. Now, remember, this OSCE is an artificial environment. It is an imperfect facsimile to the clinical encounter. It's just about getting as many marks as you can. So what I do is, so we've gone past that 1 minute base rate of disease. What sort of presentation is it? Get the bedside manner out of the way early. Hi there, I'm Mo. I'm one of the medical students. I've been asked to take a history or an examination, depending on what kind of OSCE it is, and set the expectations very clearly when you get through those initial niceties. I'm sorry to do this, but in the interest of time, I'm going to be asking questions fairly quickly. Some of them will be yes/no questions. It'll be a bit rapid fire. Is that okay with you? The second you get that consent, you fly. All right, you fly through your examination, you fly through your history. You've done that, you've ticked that off, you've set the conditions, and you move on. You break the fourth wall. All right, that's actually something I learned from Tom, back when I was an MD1, and it served me very well since. So get that bedside manner out of the way very early. When you're doing examinations, so we're talking about two things at the same time: history and examination. When you're doing the examination, do the core examinations first. Remember, it's about structure and process. There is scope to become creative with your examinations on a discretionary basis further in your medical degree. But if you've been told to do a lower limb neurological examination, do a lower limb neurological examination. Do your gait assessment, do your tone, power, reflexes, coordination. Don't do any sort of additional things that you've seen in tally until you've done the core conditions. Then you can flex a little bit and throw in some dynamic moves, extra things. Maybe it's vertigo, so you throw in a hints assessment. Hey, look at me, I'm an MD1 and I know what a hints assessment is. So some of that stuff you can do later on, but do your core examination first. And same thing, set expectations very clearly. I'm going to start by examining your heart, and then we'll come back and look at specific things. And you might want to do a Valsalva later on. That's up to you. Now, there is where we're very close to putting together the puzzle of the perfect sort of 100% history. Now, I want to give you a hint. It's like a long form history you sort of need to do in MD3 here at the University of Melbourne. And I scored full marks on this one assessment last year. And 2 times in the course of that sort of like extended OSCE, it's sort of an extended sort of case-based OSCE, I said this. Sorry, I might take a moment to just think about this. and I sat silent for 10 to 20 seconds, and I did that twice. What the point I'm circling is that in the pursuit of that 100% OSCE, you need some escape maneuvers, some rescue maneuvers. You know, sometimes shit goes wrong. You know what I mean? Sometimes you forgot the base rate of disease, you got frazzled, it propagates into a bad history. Now you're getting confused. This is something you thought you knew. What do? There are a couple of things you can do. Number one is you can, there was that initial categorization I told you about. You know, there are presentation specific stuff and there's stuff like fatigue that needs a head to toe assessment. You can always revert to a head to toe assessment, and that will weed out the positive findings that will push you in the right direction for this case. That's number one. Number two, and this will make you look really slick, is you stop and you summarize the case. Okay, so James is a 53-year-old gentleman who presents with 6 days of intermittent chest pain and palpitations, worse when he's asleep, worse on exertion, in the context of a recent mitral valve replacement. He has a history of smoking, has these features, denies these features. You say that in the middle of the case. Now you've gotten your bearings and you look really slick to the examiner. So remember, you can get a ton of marks without knowing anything about what's happening. Now, at the end of a case, so this is probably outside the scope of an MD1, so I'm going to leave this, I'm going to keep this very brief, but you will have seen it at the end of your OSCE cases. You're asked to summarize a case, and something you're going to be asked to do very often next year. Sydney, I think Sydney has reverted to sort of 1 year preclinical. It used to be 2 years preclinical. So I think you're on the wards next year, right? Either way, something people like to do to terrorize medical students is ask them to summarize a case. And that's a skill you want to get good at very quickly. Just very quickly, patient's name, age, occupation, if it is relevant, where they're presenting from, and what they present with, with a history of this relevant context. Okay, what does that actually mean? So it's similar to sort of what I said earlier. James is a 36-year-old gentleman. 36-year-old, maybe ex-smoker. That might be a relevant piece of context. James is a 36-year-old ex-smoker presenting from home. Okay, now I know where he came from. Is he coming from a tertiary facility? Has he been referred from his GP? Presenting from home with 6 months of worsening shortness of breath on exertion, with the back in the context of a 40-pack year history of smoking. 40-pack, he's 35 years old. That makes no sense. But the idea is I'm sort of laying the seeds of what I think the diagnosis may be. He describes his pain as his shortness of breath as a worse on this, on this, a non-productive dry cough associated with it. He denies features of night sweat. He denies constitutional symptoms. He denies coryzal symptoms. He denies XY, other things that sort of signal to the marker that, yeah, I have actually considered that it might be a cancer that's developing in his lung, and I know that's not the case. And they know that because you said he denies features of constitutional symptoms. And you finish off with, given this presentation, I feel like the most likely diagnosis is X. Again, these are bonus things, these are extra things. Don't worry too much about this at your level. And yeah, just remember that the questions at the end, at this point, your fate has been sealed. They account for a very small part of your thing. I just want to briefly make the comment that whatever you did before to get into Sydney Medical School has no bearing on how good you are going to be at this OSCE. Okay, the GAMSAT, whatever you did, no bearing on how good you're going to be at this. This has no bearing on how good you're going to be next year as a clinical student. That has no bearing on how good you're going to be as a doctor. These are artificial, hermetically sealed chambers. You just got to get through it, get the marks you need to get, try to learn the process, because that's sort of understand the pedagogical arc of your medical school, and move on from there. Now, before we get into the case, so given what Sidiptus told me, you will categorically not get this sort of station yet, but you might at the end of the year. So I'll mention it very briefly. There's a specific subset a substrata of cases that are counseling cases. So they're not actually a presentation, but counsel on vaccinations, counseling on weight loss, counseling on the cessation of some other behavioral thing. Just assume, these are very brief points because they don't really relate to your OSCE. Assume the majority of your marks are for emotion and bedside manner. Really understand the patient's point of view, let them speak. It's a lot of listening. I know it's sort of weird because you're meant to do all the talking in OSCE. This is really about stepping away and knowing what not to say, and make sure the patient feeds back what they know to you. We'll leave that there because it seems like that's probably not what you're going to get next week. So now we're back in Oscar. This is the thing you've been using for the last however many. And look, so you can see you can use the system to sort of like to create that list that I told you about. You can go to musculoskeletal, toe pain you might get, back pain you might get, hip pain you might get. These are all fair game, really. So let's go to this headache case that I have here in the slides. Okay, this headache case that I have here in the slides. So this is sort of imagine, and you can use the voice thing at the moment. I won't use it. I'll just type because it's a little faster. But yeah, so you've walked in, well, figuratively walked in. I think it will probably be over Zoom. So you're in some pre-check room. They check your card. You got to do all of this bullshit that you normally don't have to do in person, but this is what Zoom assessments are like. And now you're in a room, finally you get to see the case. You have 1 minute in this pre-room. Gabrielle Walker is a 35-year-old mother of two, that seems important, who has presented to general practice today with headache. Please take a history from Gabrielle with the aim of developing a diagnosis. So in this 1 minute, what did we say we do? We have the base rate of disease. We kind of know the base rate of disease because we've done our due diligence. We've done a small sort of headache page. It could be pen paper, it could be Google Sheets, could be Evernote, could be Notion, whatever you want it to be. So we have a basic sense, and I'm gonna keep this there. I'm gonna use, I wasn't planning to do this, but I will keep this there as a kind of index or a kind of proxy for your memory in the moment. Like, this is the prep you've done, and remember, look how simple this is. This won't take more than a day to do for all the conditions that you have on the 28th of June. And remember, this is to ace the history. To pass it, all you need to do is just like memorize the structure and just like regurgitate it. It doesn't even matter if you get the diagnosis right, you'll pass. Like, if you're just trying to pass, you don't even need to watch the rest of this. You can actually just leave. Oh, it's in person. Yeah, beautiful. All right, so that's good. So ignore what I said. If it's in person, it's actually way easier. Like, it's just better in person. I sort of won't get stuck in the weeds there. So 35-year-old mother of two. Okay, so I'll redo this scenario then. You've actually lifted the paper. You're in front of the door. You see Gabrielle Walker is a 35-year-old mother of two, presented to GP. That's important, with a headache. All right, so already that tells us a few different things. I have this in my head, base rate of disease. And the other thing that I have in my head is that this is probably going to need a particular kind of history. This is not a head-to-toe kind of assessment. All right, so at the end of the day, this is still, oops, I can't even see my screen. So, all right, I'll just operate blind. Hey, can you help me out? So I'm going to skip the niceties. You can do all the niceties, and you're going to get marked for all of these things. But just this is purely illustrative. Where is the pain? Something along those lines. So a headache history really is a pain history with a number of things sort of added on top. So she has it right through this region of my head here, right across my forehead there. So she has a bilateral headache that has some sort of retroorbital feature there as well. Does the pain radiate anywhere? All right, so you'd be asking some or whatever mnemonic you've learned. Some people learn Socrates. It's really sort of medical school dependent. Pain doesn't radiate anywhere. How bad is the pain out of 10 or 19? Maybe also 19. I think she should be able to understand. I was trying to say 10 there. All right, the headache itself isn't too bad, but it's been so constant it's really wearing me down. So you'd probably want to know a little bit about what relieves it, what aggravates it, that sort of thing. I'm going to move on because this is more illustrative than anything else, I'd want to know some of the triggers. All right, so this is a headache history, is really a pain history with a couple of extra things you want to know. So does anything trigger the pain? And at the moment, there's nothing to suggest to me that it is, one of the dangerous sort of like red flag conditions, subarachnoid hemorrhage, whatever the case may be. But, I might want to ask some questions anyway to rule it out. And in a 100% sort of perfect history, they want some indication, some signal that you're ruling out the things that will kill a patient. And remember, I sort of said this earlier, this is really in the pursuit of making sure that you're not murdering patients. And showing that is kind of a necessary step to getting 100%. So maybe it's stress related, it's coming to parent-teacher interview. So this could be a red herring, it may not be a red herring. It might actually be uncovering what is actually a berry aneurysm that's waiting to explode in her head. But so far, these things do sort of make sense. But, there might be a red flag condition that I might want to rule out. So, meningitis is really something that I'm kind of scared of. And so is a subarachnoid hemorrhage. So maybe I ask for features of meningism. Do you have any neck stiffness? Yeah. Is it worsened by light? Okay, so that's not pathognomonic for meningitis or anything, but that's something that I'd want to keep in mind. Do you have a fever? All right, and you might want to ask a few more questions about sort of distinct neurological features. Do you feel the headache coming on? How bad is the headache? Is it sort of disabling? Is it a migrainous type of headache? Are there infective causes? Have I ruled out some of these red flags? Is there any change to your vision? Okay, so now remember what I said earlier. I said a history is in three parts. It is the presentation specific stuff, so headache being a bit of a bastardized hybrid of a pain history with a couple of other things, or triggers, red flags, so on and so forth. The second part, well, the third part is the diagnosis, which is almost inconsequential. It actually doesn't matter too much that I know exactly what it is, whether it's medication overuse headache or a tension type headache, but it does matter that I'm heading in the general right direction. And that middle bit there, which is easier to forget because you're stuck in the maelstrom of this fairly sort of like heavy history. We could keep going ad infinitum into a headache. You want to ask all of that stuff there. Are you vaccinated? That have marks associated with it. Do you have any significant conditions that run in your family? Can you tell me about your past medical history? Do you smoke? Smoking alcohol would actually be an extremely important thing to do here in a headache history in any case. So now you've done all of this. If you're stuck, so we're 3 minutes into so this is Tuesday, you're starting to waffle a little bit, you're starting to get a little bit stuck. What exactly is it? Because you don't have this by your side, this is not there. You're starting to get a little stuck. You don't know what it is. There are a couple of things you can do. You can do a head to toe assessment. So you can ask, chest pain. But this will be a nonsense entry that the AI will not understand. But this is me sort of just typing this for you. Chest pain, shortness of breath, palpitations. Okay, I've sort of covered the cardiovascular stuff. Now I ask some neurological stuff. Change in consciousness, memory, other cognitive faculties. Headache, obviously she has an actual headache here, so I wouldn't ask if she has a headache, but these are some of the neurosymptoms you might want to ask. Muscle weakness, sensory disturbance. Then I might want to go into sort of like an endocrinological symptom and sort of ask them sort of thyroid features, and eventually somewhere in that sort of head to toe approach, I'm going to rescue myself because the examiner, sorry, not the examiner, the actor will be forced to actually corroborate what you've said. Actually, yes, I do have an infection. Actually, yes, I do have weight loss. And then that will refocus you. Alternatively, something else you can do, like we said earlier, is summarize the case. And that's my favorite thing to do. Gabrielle is a 35-year-old mother of two who presents with this many weeks of headache that she describes as this, and this. She doesn't describe an aura. It's not particularly disabling, but it is unrelieved by a simple analgesia that she has tried. This is in the context of these stresses, X, Y, Z, and I'm painting the picture of a tension type headache. She denies features of meningism. The headache doesn't appear migrainous in nature. Moderate social alcohol intake, so on and so forth. So now I've done this. That probably hasn't taken more than 30 seconds, but it's really reframed me. And it's a bit of a red herring because it's actually kind of like distracted the examiner from the fact that you're actually quite stuck, and you've turned that into a moment of extreme competence. And that's something that I've used to save myself from quite a few pickles. So I promised this wouldn't take too long. We're 37 minutes in. This is where you would summarize your case. In your OSCE, you'd be summarizing in the middle of the case to reframe yourself. Sometimes, even if I'm like perfectly fine in the case, I'll summarize anyway, just because I know it comes across as quite good to the examiner. Questions at the end, you probably have a couple of questions depending on how your medical school does it. In Oscer, we give you 5 questions. Don't worry, your fate has been sealed at this point. This is just bonus stuff. Do not be too concerned. This is not what you're being assessed on. Remember that this is about structure and process, and this stuff, they're bonuses. Okay, you're going to get there, but it's about not killing patients. That's what it's actually about. So haven't diagnosed the case, I haven't done anything, so sort of skip through it. You see how you rank. You see how you rank amongst your fellow Sydney medical student, medical school sort of colleagues. You can see exactly how you've done very systematically in every single criteria of a history. So you can imagine if you do a few more headache histories, we have plenty of headache stuff in Oscer, you can actually get to a point where you're just scoring perfectly. Obviously, this wasn't there when I was in MD1. Oscer didn't exist, but I can see how this would have actually saved quite a bit of time, because instead of sort of just like peppering ad infinitum a friend until I got good enough that I could walk into the exam and do well, I just do enough of these cases that I'm consistently scoring the full set of marks for each one. And at that point, it's really just muscle memory more than anything else. And you can see that the differential diagnosis. Tension headache was the most likely here. You don't really lose marks for saying it's a migraine. There's nothing that I really asked specific. There's nothing I asked in my history that pointed specifically to a tension headache, because I didn't ask those questions. But had I asked them, tension headache was by far the most likely option here, and some things that you wouldn't go amiss if you considered giant cell arteritis. Again, not a very common thing, characteristically high ESR, but she did say there was some retroorbital pain, and there are a few other things it can be. All right, and you wouldn't go amiss with any of these things. And you would come back, see how you're going, see how you're traveling on a macro level across all of the different systems, and you would sort of know whether or not you're on track. And there are a couple of extra things you can do. You've already had 7 days of Oscer, so I'm not going to get through it, but you will have seen Learn Mode if you want to learn a presentation from ground up. Scripts, this is something I wish was there when I was in MD1, where I was looking for OSCE templates. You'll see my history is full of OSCE templates. Well, we've turned every single one of our cases into a template so that you don't have to do that. If one of you has Oscer, you don't even both need to have paid Oscer. One person has Oscer, and you can just share it, and you can use this. You can use our cases as OSCE templates, including that Gabrielle case we just did, and you can go a little further and actually explore some conditions using our proprietary medical knowledge graph. I won't get into that either. So yeah, I promised this would be pretty short. It went to 40 minutes, but I hope it wasn't too boring. Please forgive me. So yeah, look, guys, all the best for your OSCE. Try to make it fun for yourself. This is what it's about. This is why you got into the game. This is what medicine's about. And just remember, base rate of disease, what category presenting complaint. Ask that specific stuff, even if you don't know what it is. Don't get flustered. If you do get flustered, head to toe or summarize the case. Ask all that stuff that have marks attached to it, even if you don't know why they're relevant. Ask it anyway. Past medical history, family history, smoking, alcohol, vaccinations, allergies, all of that stuff. And if you don't get the diagnosis, it doesn't matter, because it's inconsequential, because you are MD1s. Take advantage of that. All right. So that's me. That's Oscar. I hope you've enjoyed your time with Oscar. Uh, if you're interested, um, yeah, it's pretty affordable. You can get on there. I won't do a sales pitch. I'll leave you to enjoy your nights. And yeah, that's me, Mo from Oscar, and all the best for Tuesday. We have one question. How's the voice recognition of Oscar in comparison to typing to the AI? I prefer typing just because I that's just what I'm used to. But 60% of our users use voice input. So the voice is good. The actual voice that comes back is pretty robotic, but the voice input's pretty good. We're working on that at the moment. There are some voice packages we're looking at to develop that so it's more sort of like human-like. But yeah, about 60% of our users use voice. All right, awesome. No more questions. Thanks, everyone. Enjoy your nights and all the best. See ya.